Right, everyone. We are at 2 o'clock, so we were going ahead and get started. My name is Dr. Tina Lewandowski, and I'm the Director of Engagement here at the ADRC. And I would like to thank all of you for attending today. Today, we have a presentation from Dr. Jaime Perales Puchalt. He is an assistant professor at the University of Kansas Alzheimer's Disease Research Center. His background is in psychology and public health, and he holds a Ph.D. in biomedicine and public health and an MPH in public health from the University of Pompeu Fabra, Barcelona. He also has an MSc in psychology from the University of Valencia. He joined the KU ADRC in 2017 after a postdoctoral position at JUNTOS, Center for Advancing Latino Health at KU Medical Center. I want to let everyone know that we have the closed captioning available today, so you will see the type at the bottom of the presentation. And please remember to keep your microphones on mute. And if you have any questions during the presentation, you can type them in the chat, and we will save plenty of time at the end of the chat or at the end of the presentation to answer those questions. And we will have the recording available on our website within 24 hours. And I will go on ahead and turn it over to Dr. Perales. And thank you so much for taking the time to present for us today.
Thanks for inviting me. Can you see my slides? You can probably see the
Yep.
Okay, perfect. Yes. So yes, thank you everyone for being here. I'm going to present dementia disparities among Latinos. I'm going to talk about different types of disparities, but I'm especially going to focus on access to caregiver support because those are the latest projects that I have and I'm most interested in right now. So basically most of the projects that we have are funded by the NIH. We also have some funding from the Mid-America Regional Council, which we're very thankful for as well. This is the outline of the presentation. And those who are here today probably know that dementia has a devastating impact. The prevalence or the risk of having dementia, be it Alzheimer's or some others, increases with age. When people 65 and over, 1 in 10 have a type of dementia, whereas when you talk about people 90 and over, it's almost 50%. So it's almost 1 in 2. And it doesn't mean that everyone is going to develop it. It's just more likely as we age, just like other conditions such as several types of cancer, for example. Dementia, if you combine them, they're in general, they're among the top causes of mortality. If you combine them with all the dementias, it's actually the second cause of death, only after ischemic heart disease. But even Alzheimer's on its own is one of the top causes of mortality as well in the United States. It's also one of the top causes of disability. And compared to adults without dementia, people with dementia have more chronic conditions, more polypharmacy use, and more hospitalizations. We tend to think of people with dementia as those being the only ones who suffer, but the reality is that their family caregivers, their families are suffering a lot too, physically, psychologically, and financially. When we think of physically, they're more likely to have stress hormones compared to people who are non-caregivers. They're more like they have a poorer antibody response, so their or immune response. They're less protected against inflammation. They are more likely to have physical symptoms such as pain, and they are more likely to use medications as well. Psychologically, which is what I'm in my research is more concerned with, caregivers of people with dementia are more likely to have depression and anxiety disorders compared to caregivers of people with other conditions, and even more compared to non-caregivers of the same age. And then there's the financial aspect as well. People who care for or family members who care for people with dementia report more financial issues compared to those who don't. Among some of the expenses, it's not just buying the medication or briefs, diapers, or other types of things, but also many family members even quit their jobs to care for their loved ones as well. So there's a huge financial impact too. Dementia, though, it is devastating, but it's not the end. We don't have a cure yet. Hopefully we will find it. we need a lot of participants, but we'll end up finding it in the end, we believe. But there's other treatments that can stabilize or delay outcomes. So there's different medications, there's exercise, there's brain training, for example, that might help with memory and thinking decline. It might help also with the decline of activities of daily living. They're not going to revert them, but they can slow it down. And then we can also treat depression, worry, and agitation with things such as, for example, psychological support, behavioral interventions, and if it's very severe, also with certain medications as well. And as I mentioned, we shouldn't forget about caregivers. So caregiver support, respite, and psychological care, behavioral health is super important to help family caregivers. Now, I was going to talk about Latinos, and to talk about Latinos, I first want to say what we mean by Latinos. And the census refers to Latinos as people who identify as such. So people who say, I am Latino, okay, that will be a Latino person. They also add this definition: a person of Cuban, Mexican, Puerto Rican, South and Central American, or other Spanish culture or origin. There is a slight distinction between Hispanic and Latino that we usually use it interchangeably, but Hispanic refers more to the region of people coming from the region of Spain, or like culturally, I mean, or the language, whereas Latino refers more to Latin America. So Spain is not Latin America, so a Spaniard would be Hispanic in the United States, but not Latino. A Brazilian person would be Latino, but not Hispanic, for example. So there's subtleties there. And when we talk about Latinos, this is a very diverse group. We got people represented, people from the United States, but they could have origins in many different places as well, and people also who come from other countries as well. So, and that in addition to citizenship status, socioeconomic status, et cetera, et cetera. So a very diverse group. And this is just an example of people that in the United States we would consider Hispanic or Latino. And you can see simply by looking at their faces how diverse this group is, right? Latinos right now are the most frequent ethnic/racial group in the United States after non-Latino whites. And then in a few years, by 2050, they're going to be almost the majority, almost as many as non-Latino whites. They're going to increase up to 30% of the population. When we look at life expectancy, Latinos have the second highest life expectancy in the United States, only after non-Latino Asian Americans. And Latinos are also the group that is going to age the fastest in the coming years. And by age the fastest, I don't mean like getting old all of a sudden, but right now they're in a younger group, and very soon they're going to be part of that 65 and older population. They are 1.5 times more likely compared to non-Latino whites to have Alzheimer's and other dementias. The reasons we're still studying, but potentially related to access to education, healthcare, and many other resources that would make you, for example, have a better heart health. And in the coming years, we're going to have a massive increase of Latinos with developing Alzheimer's disease, because as we mentioned, they live a long time and they also have a higher risk of dementia. So very soon, unfortunately, we're going to have a tsunami coming our way in this Latino community. And therefore, there's a lot we need to do to address this public health issue. This on the left, what I'm showing here is out of the people who have a memory and thinking problem, 46% of non-Latino whites have been told by their doctor that they have dementia or a cognitive disorder, which is already low. If you look at Latinos, it's even lower, it's 34%. Now, out of people who have Alzheimer's, half are being treated with cholinesterase inhibitors. It's even lower, again, in Latinos. And then behavioral symptoms, these are depression, anxiety, wandering, paranoia, are also more common compared to non-Latino whites in the Latino community. As you can see, the same applies to African American and most of these things. Ooh, happened here. Okay. Why should we focus on Latinos besides all this? Well, we already mentioned that they have a higher dementia risk. They also have more behavioral symptoms. This is a behavioral symptoms one by one, and you can see how they're higher. The risk is higher compared to non-Latino whites in basically every single symptom. Latinos have a higher probability of becoming informal caregivers as well, for different reasons that I can respond to later on if you have that question. And Latino caregivers are more likely to have depression and poor physical health, and also less access to caregiver support, which is what made us want to address this problem in our research. There are many interventions for caregiving support, but very few have included Latinos, and even fewer have centered the intervention in what needs Latinos have and how to address the barriers that they experience to accessing these support groups, right, or support interventions. If we're not including Latinos and we're not centering intervention in Latinos, our interventions might simply just not work for Latinos, and we might be creating in research interventions that work for other groups, but not for Latinos, and creating disparities and making them bigger. So that's a big problem. Some of the barriers that Latinos experience is they have higher risk of time constraints. Latinos are a sandwich generation very, very often, and that means they're not just taking care of their parents with dementia, but also their children. They're also less likely to afford someone to care for their loved one while they're doing other things. They're more reliable on public transportation, which usually is unreliable in many of our cities, unfortunately. They also usually cannot afford many of the programs that are out there for caregiver support. And then there's also the issues of many of them mostly speak, about a 50% will speak Spanish as a first language, and some of them might not even speak English. And the interventions out there are usually in English, very few are in Spanish. And there's cultural barriers as well. There's a high stigma, for example, in this population about having dementia. By this graph, I simply mean that text messaging might be a great solution to deliver programs for caregiver support. Why? As you can see on the left, most people own a cell phone. We almost everyone has a cell phone nowadays, right? But when you look at computers, Latinos and African Americans actually have they're not as likely to have computers. So the intervention should be on computer. It should be on cell phone, and also text messaging. Look what happens here. Latinos are the highest users of text messaging technology versus, for example, internet use on your phone or video chatting. So text messaging seems to be the way to go if you want to reach a population that's underserved. In addition, you can text people and they can read their text messages whenever they want at whatever time they want. So you're reducing that reliance on a specific time and a specific place. This very crazy slide is simply the model that we used and the process that we used to develop the first ever text message program to deliver caregiver support. In general, for caregivers of people with dementia in the whole world. Now, we thought of Latino specifically because we think they might be the people who might benefit the most. But as I will tell you later, we're expanding that to other groups as well. Intervention that we conducted was a 6-month intervention. Give people a survey at the very end and at the very beginning, at the very end of those 6 months, to ask them about things such as how much do you like the program, or how depressed are you, that kind of stuff. And I'll show the results later on and you'll see a little better. But in this intervention or program, they were receiving approximately 1 text message per day. At the very beginning, a few more, but mostly 1 message per day, very short messages, educated them about Alzheimer's and other dementias, educated them about skills to cope with stress, or skills to address the behavioral problems of their loved one with dementia, etc. And they didn't just get messages, they could actually respond to us as well. What are called keyword messages, so specific keywords like the word stress will automatically have a response to them of a specific text message to help them cope with stress, for example. And there were several others. We included Latino participants who were English or Spanish speakers and who provided care for a loved one with dementia. This is just simply to show the types of messages. I kind of explained these two. So the automatic messages that they get every day, the keyword-driven ones, these are all the keywords that they can use. So you could use family for how to receive family support, on how to communicate with the family member with dementia, resources in the community, at home, for example, to address home safety, to make the home safer, etc. And they also had the option to send live chat text messages. And that means you could text an actual person who would be on the other side of the screen, responding to them during business hours as well. So 3 types of interaction: automatic messages that you will receive, keyword messages that you can request, and then actual human chat messages that you can also request. This is just a description of the sample. People were mostly, their caregivers were mostly within 35 to 64 years of age, mostly women. As you can see, the vast majority were women. The vast majority from the Midwest, but because this is text messaging, we got people from all around the country as well. Country of birth, people from Mexico, the US, and other places in Latin America. These are all Latinos, but because Latinos in ethnicity, they also report their race, right? So we had 9.2 white Latinos, 8.3 multiracial Latinos, and 62.5 of other race Latinos as well. Those are just some examples. And I'm gonna, most of them just from here, I'm gonna highlight that most of them were adult children of people with dementia. That's, I think, the most important thing I wanted to highlight from this one. And these are the characteristics of the people with dementia that they were caring for. As you can see, we actually had some people who had developed dementia before the age of 65. This is pretty rare, but there are some, especially when you're talking about frontotemporal dementia or early onset Alzheimer's. We had a few of these people, unfortunately, developed it as early as that, but most people were 75 to 84. The men to women ratio was smaller than the caregivers. Most of them were Latino themselves. Most of them had Alzheimer's, but as you can see, we also had other types of dementia: vascular dementia, frontotemporal, and dementia. They couldn't specify which type of dementia, but they had the diagnosis. And many of them, unfortunately, didn't have any health coverage. Almost a third of them didn't have any kind of health coverage. And usually they're very underserved. They don't even know what to do. They don't have access to education, to support, so etc. From here, I want to explain from here is mostly this part on the right, and this is what we call acceptability. This is satisfaction. 1 is very low, 4 is very high. So everything was 3.5 or above, which means people were very satisfied with the intervention. They thought the intervention was very helpful to understand dementia, help themselves as caregivers, and to help their loved ones with dementia. What I'm showing here is what we call health outcomes. So this is this light blue is the depression of the caregiver. This one is the burden of the caregiver, a sense of how competent the caregiver think they are in caring for themselves and their loved one with dementia, their levels of strain, of knowledge about dementia, and the neuropsychiatric symptoms. These are the behavioral symptoms of the person with dementia. Basically, all these outcomes improved to some extent from at the very beginning to 6 months after. So we showed that we were able to move the needle here in improving outcomes. Now, remember that it's a pilot study. The sample size, the number of people participating was very small, but we're showing some effect here. So the limitations, what I want to highlight from here is very few were men. We need to get more men in general. In my studies with Latinos especially, but I think in general, I wish we had more men participating in this research. It's usually women who take the lead in this. So thank you all anyway, but for that. But again, we need to get those men to participate as well to be able to help them. And so with this, we were able to show that Quitatext, the program that I described, it's feasible, it's acceptable, people are satisfied with it, and it sounds like it might be efficacious in improving the quality of life of caregivers and their loved ones with dementia. And just a little shameless plug here, I wanted to introduce two other projects that I have right now. They're very, very similar. The first one is called Alias Latina, and it uses the same program with text messaging, but with additional monthly phone calls. Okay, so it's 6 months as well. They receive one message per day approximately, and additionally, they have the option to be in monthly phone calls to listen to what their needs are and to help them address those needs. Okay, it could be finding a free wheelchair in the community or help them complete a respite care grant for their family, etc. This is nationwide. We're recruiting 100. In the previous one, in the previous study, we recruited 24. Now we're recruiting 100 people. So we anywhere in the country, including Puerto Rico as well. This one is specifically for Latinos. That would be the person with dementia needs to identify as Latino. Then for those living on the Missouri side, we have a very similar project that's only text messaging. Okay, we're not doing the phone calls here, but we adapted to other groups in the community, including people living in rural areas, African Americans, etc. So we're enrolling people, whatever their ethnic background is, as long as they live in 5 counties in Missouri, and those are Cass, Clay, Jackson, Platte, and Ray County. These are all free. This is actually a service project. It's not even research, but again, they're all at no cost. Okay, and yeah, feel free to let us know if you're interested in participating. I can tell you actually the number here: 913-588-0555. And thank you very much for your time, and I'm here for any questions that you have. Thank you.
Thank you so much for that great presentation. Very informative and good information that I learned as well. And we definitely appreciate your work. Looks like we already have a question in the chat from Kristen, and she is asking, is this increased rate for Latinos in the US or worldwide?
So the higher risk, well, I'm not able to see, hang on. I can see it. Okay, I can see the screen now. The higher risk is for Latinos in the United States. And Latinos is a very US-centric term, actually. So nowhere else in the world people use the term Latino to refer to any group. We would probably say this person is from Mexico, this person is from Argentina, and stuff like that. It's just it's a very US-centric term. So, but anyway, the risk is higher in people of Latino ethnic background in the United States. That's a very good question, though. It's as I mentioned, it looks like the reasons, even though we need to do more research about this, the reason why they have a higher risk is potentially related to their lack of access to many different things, education, healthcare, etc. So, for example, if you have a low socioeconomic status, you probably live in a deprived area where going out for a run might even be dangerous. So you can't do exercise that much, right? Or you live in a food desert and it's hard to access healthy food, or you don't have insurance and you delay going to the doctor until you are very sick, and therefore you can prevent dementia, or try to prevent by reducing the risk of diabetes, or if you have diabetes, take a medication for diabetes. Then there's also the language aspect that in many cases there are many Latinos that come from a different country where they didn't speak English, and they come here and they might understand how things work. They might not find resources in their primary language, etc. So that's where that's mostly where we think, and the data shows that the issues that there are. So in Mexico, for example, it'll be a completely different story, because they wouldn't have, the majority, almost everyone is Latino there, so they wouldn't have that issue. You have people with very high resources and people with very low resources, people in the middle, just like any other country.
Thank
And
you.
they speak Spanish there,
So language is not.
most people as well. So it's a very different story. Do you have any ideas to why Latino men are less likely to take part? Well, I think it's men in general, though. Men in general are less likely to go to a doctor. They're less likely to talk about their problems in general, health problems in particular. It might be more likely in Latinos, but I think it's in general, though. I actually don't have data here to say that it's more likely in Latinos, though. It might be, it could be, but I'm not 100% sure. What I'm saying is among men, in my research, they're less likely to participate in research because I work with Latinos specifically. But if I work with other groups, I would probably see the same thing. It's women tend to be more concerned about health and even about the health of their families as well. Many times when you have a man, it's because their spouses, suggest that they participate as well. So it's usually what you see, and then they participate more in research, and also in my study, I must say as well, that women are more likely to take on all these caregiving roles in the family, and therefore they're more likely to participate also because they're more likely to be a caregiver as well. But apart from that, there's the lack of the smaller interest of, I don't know if it's interest itself, but whatever the word is, of men to participate in research too.
And I'll say anecdotally, well, I agree with you, Jaime, and anecdotally for the research studies that I help recruit for, oftentimes when we're looking at the individuals who have participated, we see that we need to focus on men as well. So we see women are definitely in there and participating, and we have a harder time finding men also. So,
that is definitely a pending issue for I think for everyone. It's getting those men to participate. We want to improve your health too. We want our research to benefit you as well, benefit you and me as a man, right? So there's a comment there, right? That's true. And I was, and what I was thinking, okay, yes, perfect. Any more questions, anyone? I love those questions though, thank you. And if anyone else has more questions, they're all good. I love questions. See, yes.
Oh, it looks like Marissa has a question.
Yes, I saw this program on PBS or something before. There are genes maybe big factors in Latinos. There's one particular village. There are so many people who had dementia or Alzheimer's disease, and it turned out to be so many people carried this particular gene. So do you think that could be a big factor?
So that's a very good question, and I'm glad you raised up that news, because I saw it as well, and I actually know the people who are doing this research specifically. This is in Colombia, not Missouri, but Colombia, the country. And there's this gene that a group, there's a village, as you mentioned, in Colombia, that a lot of people from that specific family who actually their origins are from Spain specifically, and basically it's this autosomal dominant. So this kind of gene that if you get it, you're definitely developing Alzheimer's, but you're not just developing Alzheimer's for sure, you're developing it sooner than usual. So before 65 years of age. Now that's a very specific type of Alzheimer's, and therefore it's not related. And again, it's just in Colombia specifically. The majority of the people that we have here are of Mexican descent, and I can tell you it's not that gene, because they would be having Alzheimer's earlier than 65 years of age, and we'll be seeing those genes as well in them. So that explains that that risk in that population in Colombia, but definitely not the ones here. But it's a very interesting study and has helped to learn a lot about Alzheimer's in general. So thank you for talking about that one.
Thank you.
And in fact, what I've read is that Latinos in general, there's more, they usually have less likelihood of having this ApoE4 gene that would increase your risk a little bit of Alzheimer's. They are actually less likely to carry that gene, that copy of the gene. But they're more likely to have Alzheimer's. So, you know.
Would you say that again? Would you say that last part again?
There's this gene called ApoE4 that increases your risk of a little bit of having Alzheimer's, and they're less frequent in the Latino community in the United States. But they still have a higher risk of developing it. So it's probably not a genetic thing. Also, Latinos have, as I mentioned, they're very diverse. So finding a genetic thing in such a diverse population is very complicated. You have people from, there's a big mixture of populations from Europe, from the Americas, even from Asia and Africa as well. So, and those regions themselves are already so diverse, right? So it's very complicated to find to pinpoint at something, but there's being research on that. So I think it's super interesting.
All right, any other questions? Okay, well, Dr. Perales, thank you so much for your time and for sharing this really valuable information and for the work that you're doing to help support those who are supporting individuals who have dementia. So thank you so much for that. Also, thank you everyone for attending. This is our final weekly webinar for 2022. So we will start up our 2023 webinars again in January. So in the meantime, if you want to check out some of our past webinars, all of those are recorded and on our website. You can also email us if you have any questions at myalliance@kumc.edu. And I hope everyone has a wonderful holiday and winter break. So take care, and thanks again, Dr. Perales.
Thank you so much. Have a great day.
You too.
Bye.